So the presentation today, which is on hormones, is a general introductory presentation. And whoever heard me speak about this last time, it will be a repeat. But I think that it sets up some fundamental concepts about hormones that from which then you can ask me questions. Because I think that's the most important way that people can benefit from a support group. Is that okay with everyone? That's a perfect definition. So hormones are signals that either go through blood, like Charmin says, or act locally from where they're secreted, and they allow different cells in the body to communicate with each other. So if you think of the body as millions and millions of cells, and each cell is differentiated to do a particular function, then hormones are signals between those cells. They tell different cells to do different things and release different things and to cause different biological processes to occur. So I think it's important to think about hormones as chemical signals or messengers. Okay. Now, so sometimes these hormones are released and they have effects far, far away from the site of their release. Let me give you an example. Gastrin is a hormone that's made by the pancreas in response to food. When gastrin is released after we eat, that hormone is released into the bloodstream and circulates through the entire body and gets back to the stomach, which is only about a centimeter away from it, and tells the cells in the stomach to make acid so that you can digest food. So now these cells are specialized because if the pancreatic cell that made gastrin right where it's supposed to be at, and made hydrochloric acid, it would digest away the entire pancreas. So it releases a signal to go into the stomach, where the stomach has a special lining and can handle the acid in the stomach. So in this way, a hormone can have an effect far, far away from where it's being released. Another example is the hormone testosterone, which is made in the testes. And that hormone will act locally in the testes and support the production of sperm. But then it will travel in the bloodstream and go through virtually every organ in the body, from the bone to the brain to the prostate to all sorts of different places, and exert a biological effect. So it can have a very local effect, and it can have a very, very far-reaching effect in many different cells in the body. Growth hormone, just to give you another example, is a hormone that's made by the pituitary gland. And it's released from the pituitary gland into a small collection of blood vessels around the pituitary gland. But from there, it traverses the entire body and has effects, again, on bone, on cognitive function, on insulin metabolism, on blood sugar regulation, on growth, and really regulates many, many different things. Even though that it's made in the pituitary, it acts very, very, very far. I think it's clear to everybody here that hormones regulate things that are very critical to function, to survival, in fact, to our body's functions and to survival. So the hormone cortisol is a hormone that, without it, a person cannot live for more than a couple of days, if that. And a deficiency of cortisol can really be a life-threatening event. These hormones regulate blood sugar metabolism. They regulate water balance and salt balance, blood pressure. So we really can't live without hormones. Another general principle about hormones is that a single hormone can regulate many different functions. Okay, let me say that again. A single hormone can regulate many different body functions. So it's for this reason that an excess or a deficiency of hormone has many different manifestations. So for example, the lack of cortisol can cause weight loss, nausea, joint aches, low blood pressure, low levels of sodium in the body, passing out, feeling depressed. So a single hormone can affect many, many different things. In the same way, an excess of cortisol can cause many different bad problems, like weight gain and diabetes and high blood pressure and osteoporosis. So a single hormone can have many, many different effects. But on the other hand, it's important to remember that a single body function is also regulated by many different hormones. So if you pick a single body function, for example, blood sugar is regulated by many different hormones. Growth hormone regulates blood sugar, cortisol regulates blood sugar, insulin regulates blood sugar. Insulin is a hormone, by the way. So a single hormone regulates many different functions, and a single body function can be regulated by more than one hormone. So there's this redundancy in the system. And let me give you a very important example of why this redundancy is so important. Low blood sugar reaction, although many people may have low blood sugars, that is mild, but a truly low blood sugar reaction can be a life-threatening event. And it's for this reason that the body has many different hormones that counter-regulate against low blood sugar. So, for example, the hormone cortisol tends to bring the blood sugar up when it's down. Another example is glucagon, which is a hormone that's made by the pancreas that helps bring the blood sugar up when it's down. Growth hormone brings blood sugar up. Adrenaline brings blood sugar up. So low blood sugar is such a threat to the well-being of the organism and can be so deadly that the body has built in several different hormones to counter-regulate that. So I think this is why there's redundancy in the system, that a single body function has many different hormones that affect it, and a hormone regulates many different functions. So that's an important principle of hormones. We categorize hormones as two different types in general. Hormones can be steroid hormones. Many of you have heard some hormones be referred to as steroids. And we also have hormones that are peptides or proteins. And this is important to understand the different types of hormones, because this is why we can replace different hormones in different ways. So for example, peptide hormones are things like insulin, growth hormone. Essentially all the pituitary hormones are peptides, are proteins. Insulin is a protein. Peptide hormones like insulin, growth hormone, all the other pituitary hormones are hydrophilic. Means hydro is water, philic means love. They love water. They're water soluble. And for that reason, they circulate in the bloodstream free-floating and unbound to any carrier proteins. Okay? That's important because of the second type of hormone, which is steroid hormones. These hormones are hydrophobic, means they hate water, and so they have to be carried in the bloodstream attached to carrier proteins. And so they're never circulating free. They're all bound up with other carriers. And examples of steroid hormones, it's like testosterone, cortisol, estrogen, DHEA. All the adrenal hormones are all steroid hormones. And one thing that links all the steroid hormones together is that they're all made from a common precursor, which is cholesterol. So cholesterol is the common building block of all the steroid hormones, whether it's testosterone or estrogen or DHEA. These are hormones that are all steroids, and they're hydrophobic. They hate water, so they're bound to carrier proteins. This is important when we try to measure hormones. Hormones that are steroid hormones that are bound to carrier proteins are going to be affected by anything that affects the carrier protein. So, for example, cortisol, which is a steroid hormone, is bound to a binding protein called cortisol binding globulin. And when we measure cortisol, we're measuring it all in the bound form. But the bound form can vary based on the concentration of the carrier protein. There are certain conditions that change the carrier protein and therefore would change the concentration of the hormone. And so for that reason, we have to find ways to measure the free hormone. And this is why when we want to measure cortisol, we try to measure free cortisol. We try to do that through a 24-hour urine test or through a saliva test, because we want to get away from that, from the amount that is bound up, and we want to get the free or biologically active form. So this is why when some of you have had laboratory tests, for example, for the thyroid, you're measuring free T4, free thyroid hormone, or free T3. It's nothing free about it. It's free in the sense that it's biologically unbound to any carrier protein, and so that's the correct way to measure it. When you measure cortisol, you measure 24-hour urinary free cortisol, or salivary cortisol, which is free. When you measure testosterone, we measure free testosterone. So whenever a hormone level is measured as a total value, it's sometimes inaccurate because of this whole issue of the binding proteins. The other important point about hormones, and we're going to finish pretty soon, and then I'll open it up to questions, is that hormones have a rhythm in how they're released. Okay, this is very, very important, has many implications. Hormones are released in a rhythm. For example, some hormones are released minute by minute or hour by hour. Growth hormone is one hormone that is released in tiny little pulses throughout the day. Okay, so this is why if you measure growth hormone levels randomly, they really don't really help you. So let me just draw here. This is growth hormone levels, and this is the time of the day. And this is a normal individual. So the growth hormone level is released in little pulses at different times of the day. Sometimes you have big pulses, sometimes small pulses. At night when we're sleeping, we have a lot of big pulses of growth hormone, and then as the day goes by, smaller pulses. So you have a very, very scattered and almost disordered release of growth hormone because it's released in a very pulsatile fashion. This is a growth hormone curve from somebody who has a pituitary tumor that makes too much growth hormone. And of course, this person is going to make growth hormone in pulses too, but is going to have more of the big pulses, relatively. If you were going to measure a random growth hormone level, and you happen to time it, and you measured this person at this time, and you measured this person with a growth hormone tumor at this time, you're going to find that they have the same exact growth hormone level. And you will be misled to thinking that both of these people are normal. But it's just that you caught it at a time when the pulse was low. So because of the pulsatility of some of these hormones, we can't just randomly measure a hormone level. You can't just go to the lab and just measure a hormone level randomly at any time of the day, especially on a hormone that fluctuates so much like growth hormone. So for this reason, sometimes we have to do provocative tests to either suppress the hormone or to stimulate it to really determine, is that hormone being made in the right fashion, in the correct amounts, or is it being made insufficiently or excessively? So this was an example of a hormone that's made minute by minute in pulses. We have other hormones that are released in a daily fashion, like cortisol. Cortisol is released primarily in the morning, and then the levels dip down as the day goes by. By around midnight, the cortisol levels usually go down very, very low to levels in the single digits or maybe even close to zero. But in the morning, the cortisol levels are high. So for example, if you measure a cortisol level on somebody and not know what time of the day was measured, you're going to be misled. You're not going to be able to interpret that test very well. Some hormones are made on a monthly cycle, right? So the hormones that regulate menses are going to be made in a monthly fashion. So we have hormones that are made minute by minute, hour by hour, month by month. In some animals make hormones, not humans, but make hormones in an annual fashion. And so some animals ovulate only once a year. And so different organisms have adapted differently and may make hormones differently, but all of the hormones have some rhythm. This issue about rhythm and pulsatility has implications as it relates to measuring the hormone level, but also in replacing it. So if we know that growth hormone is primarily made at nighttime, it would be logical to replace growth hormone at night, to give the injection of growth hormone at night in somebody who has growth hormone deficiency. In somebody who has cortisol deficiency, because cortisol is made primarily in the morning, it's best to give it in the morning, or at least most of it in the morning. So this rhythm of the hormones has implications both in measurement of the levels and also in replacement in patients who are deficient. There's two more points about hormones, and another important one is that hormones have feedback regulation, feedback mechanisms. What do I mean by that? What I mean is that when a hormone level is made in excess or an insufficient fashion, the body tries to regulate that. So for example, if we come and remove somebody's thyroid gland, the pituitary gland is going to sense that thyroid hormone is missing and is going to send signals to stimulate the thyroid to make more hormone. So this is called feedback regulation. If now I come and give somebody excessive amounts of thyroid hormone, the pituitary gland is going to sense that and make less signal for the thyroid to make its hormone. So it has a negative feedback. And this is the way that hormones are being regulated from minute to minute. An example I think everybody could relate to is that when we eat a lot of food, especially if we eat something that has a lot of sugar, obviously our body wants to make lots of insulin in order to utilize that sugar and to push that sugar into cells and tissue so we can use it as fuel. When we're not eating, we don't want to make any insulin. So this is feedback regulation. Food feedback regulates and stimulates the release of insulin, and insulin is released. And when we're hungry and when the blood sugar is dropping, that causes inhibition of insulin release because you don't want any more insulin when you don't have any food in your body. So there's this constant feedback, and this feedback is happening minute by minute in order to keep hormone levels consistent or at least mimic their usual diurnal variation, as I showed you before. Hormonal disorders then become very easy because a hormonal disorder can really result in two different things. The bottom line. Either a hormone can be made in excess or a hormone can be made in an insufficient manner. So this is fundamentally, it's very, very simple. Diseases occur when we make too much of a hormone, or we make it at the wrong time, or when we don't make enough of it. So that's the bottom line. But how does that happen? What are the diseases that make some hormones made in excess, and what are the diseases that make some of the hormones in an insufficient fashion? And if you think about it, there's really several mechanisms where hormonal disorders can occur. The main mechanism is that the glands that make hormones are susceptible to tumor formation. Okay, so the endocrine glands, the glands that make these hormones that we're talking about, are very, very prone to developing tumors. Now, fortunately, these tumors are benign, not cancerous, but because a tumor can overproduce a hormone, that could cause problems in a patient. So if you look at every gland in the body, whether it's the pituitary or the thyroid or the adrenal glands or the ovaries, they're all susceptible to forming growths or tumors. These tumors can make extra hormone, but also they can put pressure in the surrounding normal tissue and cause an insufficient amount of hormone from being made. So, for example, a pituitary tumor that is enlarging can make too much of a hormone, like growth hormone or ACTH, but also that mass from the tumor can put pressure on the rest of the pituitary gland and cause the rest of the pituitary gland to fail or not produce enough of the other hormones. So one of the main mechanisms where endocrine diseases occur is due to tumor formation. There is a statistic out there, which many of you are familiar, that about 15 to 20% of people, of everyone, has a pituitary tumor. So that's a very, very high statistic. Fortunately, most of these tumors are not hormonally active, but you have to make sure, that that's the case. When somebody comes with a pituitary tumor, you have to make sure that you're not dealing with a hormonally active tumor or a tumor that's putting pressure and causing some deficiency of other hormones. If you do MRIs on people, let's say with abdominal pain, you'll find that 10% of everybody who you do an MRI on will have an adrenal growth or an adrenal tumor. Again, most of these adrenal tumors are incidental and don't cause any problems, but it's important to check into it. So tumor formation is a major mechanism where hormonal disorders can occur. The second most common would be a problem with the immune system. Okay? Endocrine glands are very susceptible to the immune system attacking them. Okay? So for example, the number one cause of hypothyroidism in California and in the United States is an autoimmune disease. It's called Hashimoto's disease, where the immune system, for reasons that are not clear, begins to attack the thyroid gland. It begins to attack itself. This is why it's called autoimmune. And in doing so, it destroys the thyroid gland and makes the thyroid gland underactive. So if you meet people who have hypothyroidism, many of them, the reason for the hypothyroidism is because their immune system is attacking their thyroid. The same thing can happen in the pituitary gland. The pituitary gland could be susceptible to autoimmune destruction. Typically, this happens after pregnancy, a condition we call lymphocytic hypophysitis. Hypophysis is another name for the pituitary gland, and sometimes after pregnancy and delivery, a woman may develop an autoimmune reaction against her own pituitary gland. And this is something that we have to consider when a woman who just had a delivery cannot lactate, cannot breastfeed. We always wonder whether this could be an issue, that their immune system is attacking their pituitary gland. The adrenal glands can become attacked by the immune system. So lots of different autoimmune processes can affect the endocrine glands, and they turn out to be one of the number one targets for the body to attack itself. Hormonal problems can also develop from receptor abnormalities. What do I mean by a receptor? Well, when a hormone wants to exert its action, so let's say that the pituitary gland is going to make a signal called ACTH, and this ACTH signal is now going to travel in the bloodstream and make its way to the adrenal glands, and the adrenal glands are going to make cortisol. Now this hormone cortisol then travels in the bloodstream and gets to its targets, and for it to exert an effect, it needs to bind to a receptor. Okay? It needs to bind to a receptor, which is sort of like a lock and key. You know, you're putting a key into a lock, and it opens up the lock, and now certain events occur. Like, for example, with cortisol, bringing up blood sugar, for example. But the cortisol has to bind to its receptor. Sometimes people have a defective receptor. And so even though that there may be plenty of cortisol, and the signal ACTH may be produced properly, if the cortisol can't bind to its receptor, then it's not going to be able to exert any action. So it's just like having no cortisol. So sometimes we have receptor problems. So there, you know, the same thing can happen with the hormone testosterone. So if a man has plenty of testosterone but doesn't have the receptors for testosterone, that man is going to look like a woman. And this disease exists. It's called testicular feminization. So this is another mechanism, a receptor problem, where a hormonal problem can declare itself. So you're making plenty of hormone, but the receptor is defective. So we talked about tumors causing hormonal problems. We talked about immune system attacking the body and causing hormonal problems. We talked about receptor problems. And the final thing is nutritional problems. I always include nutritional problems because sometimes if the organism or the person is deficient in vital nutrients, then these hormones cannot be made. I told you that for the steroid hormones like testosterone or estrogen, the building block is cholesterol. And so if somebody is profoundly deficient in nutrients and now their cholesterol is so very, very low, then they're not going to be able to make testosterone or estrogen. This is why, for example, somebody who is nutritionally deprived may stop having menses. This is why a marathon runner who is burning so many calories and has become so lean and underweight stops having menses. They stop making estrogen. So nutritional factors are very, very important, and they factor in to the production of hormones. Usually nutritional problems will cause a deficiency of a hormone because you don't have the building blocks to make a hormone. But sometimes nutritional problems cause stress on the body, and cortisol is a stress hormone, so sometimes in severe nutritional deficiency, the body is so stressed that it actually makes too much cortisol because it feels like it's under a constant stressful stimuli. But nutritional factors primarily cause hormones to be deficient. So we have those four mechanisms, and I think that all endocrine disorders can fall into one of those categories. So hormones can be high or low, and these four different mechanisms are how they can be high or low. So with that introduction, I think you understand, I hope you understand a little bit about hormones, how they function, and how they can be defective. And I'll open up this to just some questions, and we can reinforce some of these points. We can talk about some specific stuff.
I have a question.
Yes.
What you talked about, the hormonal cycles. For example, the prolactin would have a monthly cycle. Okay, so if I were to check blood tests on a person that has a prolactinoma, is it better to check it before the period, during the period, after the period? Doesn't matter?
That's a good question. Prolactin does change a little bit during the cycle, okay, but it is not enough. The normal range has enough of a range that it takes into account the different times of the cycle.
Okay.
So if a prolactin level is elevated, regardless of when you drew it in the cycle, it's an abnormal value. Did that answer your question? So let me just say it a different way. So a normal prolactin level for a woman is between 5 and 25. Although the level can fluctuate during the cycle, like for example during ovulation, the prolactin level can be a little bit higher, it still will fall in this range. So if you have a person who has a prolactin level of 26, then that's abnormal. Okay?
Can I ask another question?
And yes, let me remember your question.
Sure.
I made this important point about one point in prolactin being abnormal. This is a very, very important point that a lot of times doctors, including me, are guilty about overlooking small abnormalities in a hormone concentration. Okay? It's very possible that this 26 is clinically insignificant, but nevertheless it merits an evaluation to make sure that the person doesn't have a true hormonal problem. So even though that a value of 26 is only 1 point above normal, it still needs to be evaluated to the fullest. Okay? Before you forget your question, let me give you an example. You forgot it already?
No,
Okay. Let me give you an example. A person can have a gigantic pituitary tumor, and their prolactin level can only be 1 point above normal. Okay? So the reason that is because the pituitary tumor is not making prolactin. It's putting pressure in the pituitary. It's putting enough pressure that it's elevating the prolactin a little bit. Okay, so unless you do a pituitary MRI, you won't know what's going on there. If that pituitary tumor was making prolactin, then the prolactin level would be in the thousands, and it's a no-brainer. But you can have a large tumor that is not making prolactin, and just by virtue of putting pressure in the pituitary can elevate the prolactin to be 26. Okay? Let me give you another example. If a woman comes in for checking their prolactin level, and the night before they had breast stimulation, that may be enough to make the prolactin 26, 27, or 30. So it's possible that the elevation in the prolactin is totally physiological, but it needs to be evaluated. If a patient took an anti-nausea medicine before you check the prolactin, that could elevate the prolactin level. Sometimes some medicines that we use for nausea cause the prolactin level to go so high that the person is spontaneously lactating. And so we have to always look at these numbers in the context of medications and the clinical picture of the patient. Okay, so small abnormalities can mean a lot, or can mean nothing, but you have to check into it. Okay, your second question.
Okay. The second question is about another thing that you mentioned. When you have a tumor, it affects also the surrounding area, so that they might be deficient in other hormones.
Yes.
So my question is, every time you have a patient, for example, again, with a prolactinoma, do you test for all the other pituitary hormones to make sure what they look like, or no?
Absolutely. You do. You do. So again, this particular, if we give this person now a Cushing's disease, so this person has a pituitary tumor now that's making too much ACTH, it's important to check all the other pituitary hormones because there could be mass effect, there could be pressure on the other hormones, and the other hormones could be deficient.
Even if it's a small tumor?
Small tumors usually don't cause enough pressure, but you don't know until you check. Usually tumors have to be greater than a centimeter to exert enough pressure to cause other hormones to go down. So you've heard about macroadenomas. Macroadenomas are tumors that are greater than a centimeter. Micros are less than a centimeter. Usually it takes a macroadenoma to cause enough pressure to cause other hormones to go down. There's another important point about checking the other hormones, and that is that sometimes tumors co-secrete hormones. Okay? What do I mean by that? I mean that let's go back to the growth hormone case. Now let's give this person a growth hormone tumor. So now this, and Cushing's is a condition where the tumors are usually small, and in fact so small that you can't see it on MRI. So it's unlikely to cause enough pressure to cause a deficiency. But growth hormone tumors, usually when they're diagnosed, they're quite large. So this person is making growth hormone, too much growth hormone, and they have acromegaly now. Well, it's important to check the other hormones because you want to make sure that the other hormones are not deficient, but you also have to check it because about 20 to 30% of people that have a growth hormone tumor, they co-secrete prolactin. So these tumors are co-secreting about 20 to 30% of the time, and they make both growth hormone and prolactin. Yeah, we often get probably 2 to 3 patients who have large pituitary, every year, 2 to 3 patients who have large pituitary tumors, and the doctor appropriately measures a prolactin level, and it's high. And that clinician assumes that tumor is making prolactin. But the problem is that you have to look at the prolactin level and the size of the tumor, and you have to correlate them. If you have a big, gigantic tumor in the pituitary gland, and it's making prolactin, then the prolactin level should be in the thousands or 10,000s. Okay? So if you have a big pituitary tumor and the prolactin is only, 50, then that's not a prolactinoma. That's not going to respond to treatments for prolactin tumors. That's a tumor that needs to be removed surgically. And the reason that the prolactin is elevated is because of just the tumor putting pressure on the pituitary gland. Whenever there's pressure in the pituitary gland, prolactin goes up from whatever cause. Do you guys know why? Why is it that prolactin goes up whenever there's pressure in the pituitary gland, whereas all the other hormones go down? If you put a mass in the pituitary gland, it generally lowers by putting pressure all the other hormones, but prolactin goes up. Why? This is like the question Sherman will give you a prize if you can get this answer.
Because it thinks you're pregnant?
I like that answer. Prolactin goes up when there's pressure because prolactin is a hormone that's under tonic negative input. Let me explain what I mean by that. Normally, all the pituitary hormones are regulated by the hypothalamus. Okay, so we're talking about the pituitary as the central regulator of hormones because it makes all these signals. But even a step above that is the hypothalamus. And the hypothalamus sends signals to the pituitary for the pituitary to exert its effects. It usually sends a positive signal. So it sends a positive signal to make growth hormone. It sends a positive signal to make ACTH. It sends a positive hormone to make TSH. But it's constantly secreting a negative hormone to make prolactin. So the input for prolactin from the hypothalamus is chronically an inhibitory input. So anything that comes and puts pressure on this inhibitory input is going to cause stimulation. So if you inhibit an inhibitory hormone, you get stimulation. Yeah, like 2 wrongs makes it higher. So because normally the signal is a signal that's telling the pituitary not to make prolactin, to keep prolactin nice and low. So now when you come and disrupt that signal from a tumor, let's say, and that signal that's keeping it low is now taken away, then the prolactin goes up. So any type of pressure in the pituitary gland, if it's enough pressure, will elevate the prolactin level. So this is why a lot of times a person can have a high prolactin level, and it's not due to the pituitary tumor making prolactin, but just due to pressure. Okay, well, enough said about that. Well, in a way, by taking away that pituitary tumor, you've actually become more normal, right? I mean, menopause is not an abnormal it's a fact of life. I mean, it may be horribly painful and inconvenient, but it is not a disease. It's not an abnormality.
So it's normal to want to go kill people for breathing.
So your body's trying to, yes, it is. Your body's trying to readjust. Your body is trying to readjust. So that's one reason, is that your body's trying to readjust. The other reason is that you in your situation, well, let's just take a hypothetical case. If a pituitary tumor that's making an excess of a particular signal is now removed, the rest of the pituitary that was normal would have been suppressed because there was so much signal coming from the tumor. Now that you remove the tumor, the rest of the pituitary is still suppressed, and it will take some time for it to wake up and regain its ability to function properly. Did you follow what I meant? You will gradually get better. You will gradually get better, as long as the surgery did not damage the pituitary gland, and if you have the right surgeon, whose office is just 10 steps from me, as long as you have the right surgeon, and you don't damage the normal pituitary gland, then it will gradually regain its ability to function properly. And what you may be going through, although not very comfortable, is just your body's way of sensing the tremendous change that it has gone through the moment that the tumor was removed from your body. So, and then everybody's sensitivity to hormonal problems or hormonal changes is different. Everybody's different. I can have a person who has a prolactin level that is 1 point above normal and have tremendous lactation to the point that it is inconvenient. And I can have a patient who has a prolactin level of 1,000 and not make a drop of milk. So everybody is a different sensitivity. A person can have a slightly low thyroid level and can be fatigued and cold and you name it, constipated and gain weight. And another person, you can remove their thyroid and they'll go for weeks without feeling anything. We don't understand why, but everybody is different. Yes, you can. If you remember the 4 different things that I said cause hormonal problems, what were they? Let's go over them again. Tumors, autoimmune, okay, receptor problems, and nutritional. You can't inherit nutritional problems, usually. Well, I guess you could inherit that too, but you really, by the definition of inheritance, you really can't inherit a nutritional problem. But all the 3 things that can affect the endocrine glands are all very strongly hereditary. For the tumors of the pituitary gland, the vast majority of them are not hereditary, but some of them can be. About 3% of pituitary tumors are genetic and familial. And if you have a family member that has one, if you're part of that 3%, you will definitely get some form of a glandular tumor in your life. The vast majority of pituitary tumors are not. Thyroid tumors are strongly familial. Autoimmune diseases are strongly familial. So now the autoimmunity can be expressed in different ways. I may express my autoimmunity against my thyroid. My brother can express his autoimmunity against his for example, his skin and have vitiligo. My mom can express her autoimmunity by making antibodies against the pancreas and develop type 1 diabetes. But autoimmunity as a general tendency is primarily genetically determined. How it's manifested can vary from person to person. So the answer is, and then receptor problems are very much genetically determined. So yes, in a large extent, a lot of these things can be hereditary. The typical hot flash is the lack of either estrogen in a woman and a testosterone in a man, and that causes vasodilation or a expansion of the blood vessels. So the body senses the lack of the hormone.
More cholesterol.
and all of a sudden the blood vessels dilate or get bigger, and the blood vessels are feeding blood to your face and other places. So that's a hot flash. You feel flushed. Now other hormones other hormonal problems can cause flushing as well. So there's a condition called carcinoid syndrome where there are certain tumors that make things like histamine or metabolites of serotonin, and these are released and cause flushing as well. But the typical hot flash that people refer to is usually it occurs at a time when all of a sudden the estrogen level is declining or the testosterone level is declining, and the body responds to that by by the blood vessels getting larger, giving more blood to the capillaries under the skin, and then flushing. Okay, so it depends on a lot of different factors. So I mean, your son had a 2-centimeter tumor, and was it making any hormone?
Yes, ACTH.
It was a tumor that was making ACTH.
How old was he? 50? 50.
So that
What a great surgeon, though.
yeah had a great surgeon. The ACTH tumors that are 2 centimeters are tricky tumors because they're not typical. Usually ACTH tumors are very, very small. So already the fact that you tell me that tumor was 2 centimeters means that your son is going to have to be monitored a little bit more carefully. The second question that is important is how effective was the surgery? Was it all removed? Okay, so that's a good sign. So
He's on hormone replacement.
so usually what we do, I mean, I think this has to be individualized, but usually what we do is after a person has had surgery, we look at all the pituitary hormones. I generally look at all the pituitary hormones again in about 6 weeks, and then again at 3 months, and then usually every year, unless there are deficiencies that I'm replacing, like thyroid hormone in this case, in which case I would check more frequently. And how long would I do it? It's lifelong. It's really lifelong. I think that the general statistic is that in tumors that are big, greater than 1 centimeter, macroadenomas, the risk of that tumor recurring, this is just a general statistic, is about 20% in the lifetime. So now not every time that tumor recurs do we have to treat it, because sometimes non-functional tumors recur and there's a small recurrence and we don't have to do anything about it. But the general statistic is that there's about a 15 to 20% recurrence rate in the lifetime. So it does need to be monitored indefinitely. But the frequency decreases. So usually it's a couple of weeks after surgery, and then a couple of months, and then annually. And we do that for 5 years. If everything is perfect, we can reduce the frequency to maybe every other year or every 2 years. So you have to look at the patient and what's going on with them. I have some patients who know immediately when their Cushing's is recurring. You know, and that because their body's changing in it, their periods stop, something happens to them, they're gaining weight unexpectedly again. They know that something is wrong, and we test them. And if that happens, 2 weeks after their surgery, I test them again. I mean, so it depends on the symptoms. You have to look back at the symptoms that led to the diagnosis and be very careful to follow those symptoms. And if they recur, then you have to retest. There's a couple of general principles. The first general principle is that the pituitary function that you take into surgery with you, usually you exit surgery with the same pituitary function. So that's a general principle. So if, for example, you have deficiency of thyroid going into pituitary surgery, you are likely to have deficiency of thyroid when you come out. About 5% of the time, 5 or 10% of the time, by removing that tumor and relieving the pressure, the hormone function can improve. And about 5 or 10% of the time, it can worsen, because in trying to remove the tumor, you damage normal tissue. But the general principle is that whatever you take into pituitary surgery in terms of hormonal deficiencies, usually you have it when you come out, with some improvement in a minority of patients and some worsening in another minority of patients. So 15 months out, if the person is still on thyroid hormone replacement, then they're likely to be on hormone replacement. The point that Charmin made is a very important point. I mean, has your son ever been withdrawn from thyroid hormone to see whether he really needs it? Because if the person has been on thyroid hormone before surgery and you just keep it going after surgery and you're measuring the levels, well, the levels you're measuring what the person is taking. So at some point, if you really want to answer that question, the hormone has to either be gradually tapered or stopped to see what is being made by the normal gland. With regard to the cortisol replacement, we talked about this feedback, that hormone's feedback. If there's too much of a hormone, that suppresses the signal for that hormone. And so what Charmin was saying is that if, for example, your son is on too much cortisol replacement, then that could suppress and not allow the pituitary gland to regain its ability to make that signal. So, you have to taper the dose to the right level. the receptor. Let's answer the second question first. The receptor problems. Usually, what will happen is that if there's a receptor block, then through the positive feedback, the other hormones go up. Do you follow what I just said? So, if there's a problem at the level of receptor through positive feedback, because the hormone is not doing its job, the pituitary gland is going to sense that hormone is not acting properly and is going to make more signal, make more growth hormone. So usually with receptor problems, through feedback, all the signals above that are going to be elevated. So that's one clue to a receptor problem. The other thing about receptor problems is that they are usually congenital. Okay, so if you have a problem, for example, with growth hormone and a growth hormone receptor, that's a congenital problem. That's at birth, because receptor problems are not an acquired condition. So usually these are documented early in life. And so for growth hormone as an example, you would have a person who doesn't grow. That's one with growth hormone. I'm not talking about a receptor problem with growth hormone. Who is a child who is not growing at all. You measure their growth hormone level; it's sky high. There's plenty of growth hormone. Growth hormone are through feedback really, really high because they're not exerting an effect, and so the pituitary is just cranking out more and more. It doesn't know what's going on. It just sees that there's nothing happening. So usually that's how. There's some genetic tests for receptor problems as well. But for growth hormone, the receptor problem is called the dwarf, and that's that's a condition that the child doesn't grow, may have problems with hypoglycemia because they don't make enough growth hormone. So all the actions of the hormone are deficient, but the hormone is high. Okay. The first question was, can a hormonal problem cause food allergies? I'm not an allergist, but the answer to that is yes. I mean, I've seen many problems who have, for example, a thyroid imbalance or a pituitary imbalance, who then have allergies. And when we re-regulate the hormone, those allergies get better. This is not very scientific. It's just a personal experience that I've had. What are the mechanisms? I'm not sure, but I think hormones have lots of effects above and beyond what we currently know. Growth hormone, in fact, is the biggest misnomer of the name, because it's only one of its functions to cause growth. There was a time when that's all we knew growth hormone did, and so we termed it growth hormone. Now we know that it probably affects every tissue in the body to some degree, and so it's probably better termed the metabolic hormone rather than growth hormone. So I think there's other factors, and allergies, yes, I've seen that. I don't know how to explain it, but I think it exists. So growth hormone in an adult is maintaining body composition. That's the simple answer. And by that I mean it maintains lean body mass. It maintains muscle mass and bone mass and causes us not to get too much fat mass. So that's the action of growth hormone as an adult, for adults. It also helps with sense of well-being. People who have adult growth hormone deficiency tend to have a poor quality of life. And actually that sounds like very vague and abstract, but in fact there are surveys and instruments, questionnaires that are used to determine whether somebody has a poor quality of life and would benefit from growth hormone replacement. A person who's growth hormone deficient and would benefit from replacement. So things like waking up and feeling like, oh, it's a good day. Growth hormone may help with that. Or waking up and seeing, having good memory, having good energy and vitality. Our ability to sweat is in part related to growth hormone. So adults that don't have growth hormone tend to not be able to sweat as much. So I think the way to answer that question and that topic is that you can either have hormone replacement or you can have hormone treatment. Okay, let me explain what I mean by that. Hormone replacement means that a hormone should be made but is not being made, so we're replacing it. Okay? If you take a 20-year-old woman who has, let's say, ovarian cancer and has to have both of her ovaries removed. This is just a hypothetical scenario. And now immediately that 20-year-old woman goes into menopause and her estrogen level goes to 0. Giving that woman estrogen is hormone replacement. You're replacing a hormone that should be made in a 20-year-old but is not being made, so you're replacing it. You want to give back things to its normal physiological state. If you take now a woman who is 52, who had normal ovary but now went to menopause, and now at 52 is having hot flashes and mood changes and all sorts of stuff, and comes to you, and now you decide to give her, bless you, now you decide to give her estrogen, now that is called hormone treatment. Because it is not normal for, it is normal for her not to be making estrogen at that age. And so that is called a treatment. Okay, so there's a difference between replacement and treatment. Replacement is replacing it when it's not made. Another example, if you take somebody who has a large pituitary tumor, and as a result of the pituitary tumor or its treatment, now that 25-year-old person is growth hormone deficient, then it would be perfectly reasonable to give that person growth hormone replacement therapy, because that 25-year-old would be making growth hormone. Now if you come and take a 75-year-old woman whose growth hormone levels have declined from the time that she was 25, but they're still normal for her age, she has no pituitary problems, and now you decide to give her growth hormone to bring her levels back to when she was 25, that's a treatment and can have consequences. Right, so the question for those of you who didn't follow it is that if a person has a tendency towards blood clots, for whatever reason, whether it's a genetic tendency or a problem with the circulation or a problem with the clotting factors, that condition makes it risky to take certain hormones, primarily estrogen hormone, because estrogens cause the blood to be thicker and may make more clots. And so if a person has an underlying clotting disorder, then yes, then always that would be more risky to take estrogen. Unless the clotting disorder is a reversible clotting disorder. Sometimes people get clotting disorder. Cushing's disease is a condition that causes increased clots. So if the clotting disorder is due to Cushing's disease, and you treat the Cushing's disease, then the clotting disorder goes away, and that person can take estrogen. So sometimes some clotting problems are reversible, and if it's treated, then you can go back on a hormone. A lot of times clotting disorders occur because of an underlying cancer, and in that situation, unless the underlying cancer is treated and completely resolved, then the use of hormones would always be risky. Absolutely, that's a good question. The imaging study will give you the answer. So if you have an autoimmune disease affecting the pituitary gland, that process is going to affect the entire pituitary gland, including its connection to the hypothalamus, which we call the pituitary stalk. So if you have an autoimmune pituitary problem, let's just draw a couple of pictures. So if you have an autoimmune problem affecting the pituitary gland, if this is a normal pituitary gland and this is the pituitary stalk that connects the pituitary to the rest of the brain, and this is a picture of somebody who has a pituitary tumor, a person who has an autoimmune problem, usually the entire pituitary is expanded, including the stalk. So now the stalk is bigger, and the whole pituitary is infiltrated by immune cells. So a tumor is a more localized phenomenon. So on imaging you can tell. On imaging is the best way to tell. Yeah, the autoimmune problems that affect the pituitary are not common. I mention it for being complete. Autoimmune diseases of the thyroid are very common. Very, very common. So antibodies against the thyroid are seen in about 10% of women. Now those antibodies may not be enough to cause the thyroid gland to fail, but thyroid autoimmunity is very common. pituitary autoimmunity can occur. It primarily occurs in the context of pregnancy and delivery. And we don't understand exactly why, but probably it's because the immune system changes as soon as somebody delivers a baby. And that can cause the immune system to now attack itself. So pituitary autoimmunity, although it can occur, is relatively uncommon. But if you have an experienced radiologist, they can tell based on the film and based on the hormonal profile whether that's the case or not. Prednisone is not a growth hormone. It's a steroid hormone. But prednisone does not cause any form of growth. Doesn't have any growth in its.
When does the body need, on a daily basis, and when does it need that hormone the most?
It's made primarily in a pulse in the morning, and a smaller pulse in the evening. So that's one of the hormones that has the daily variation, that it changes from morning to evening. So normally when we replace cortisol, which is what prednisone is doing, we like to give a slightly higher dose in the morning and a lower dose in the afternoon or early evening to mimic the normal physiology.
So is it bad to take your medication?
Is it bad to take it all at once?
Yeah.
It's more physiological. I mean, some people don't notice a big difference, but there are some people who are sensitive. So it's always better to try to do it the way that the body is made to make that hormone. Now, prednisone is a hormone, is a synthetic form of cortisol that has a longer half-life. So there's some, as we're tapering people off of prednisone, sometimes we give it to them once a day. But if you're going to be on it as a chronic replacement because your pituitary gland doesn't make enough signal for it and you're going to be on it forever, it's better to give it in that fashion where you give more in the morning and a little less in the evening. It would be more physiological to replace it the way that the body would make it. And I think, many people probably in this room who've had pituitary problems who do everything right and take their hormones the right way, at the right time, at the right dose, and still have days that they feel crummy and they don't feel right and they have aches and pains and that, and their answer to that is that, cortisol was not meant to take as a pill and then to digest from your stomach or your intestines and then get into the circulation. Cortisol was to be made through a signal from the pituitary gland telling the adrenal glands exactly how much to take for that moment in time. It's being regulated on a minute-by-minute, second-by-second basis. And when we give replacements, we're giving something as an injection or something as a cream or something as a pill. It was not meant to be given that way. We're doing our best to replace it. So even in the best of methods of replacement, some people still have symptoms. But the things that we could control, we should control. So this is a specific question about what are the best treatments for prolactin tumors. And this is there's no right answer. I mean, some people. Let me just start off by saying that for prolactin tumors, there are very effective medical treatments and there are very effective surgical treatments. Okay, and I think ultimately it will boil down to what is the patient's preference. As long as you have a good endocrinologist who could manage that patient medically properly, or if you decide to go to the surgical route, you have an experienced pituitary surgeon, then either option could be a good option. And you have to weigh the risks and benefits of each one and come up with whatever you're comfortable with. So we'll talk about it. I mean, prolactin tumors are the most common tumors, so maybe we could spend a few more minutes on talking about what are the benefits of medications, what are the benefits of surgery, and risks of each one. Well, the benefit of the medication is that you don't have to have surgery. Okay, so you take a pill with cabergoline or Dostonex. It's usually twice a week, so you don't have any of the risks of surgery. 3 millimeters, small. The good thing about it being small, let me just interject, is that that's the one situation where surgery can actually cure it. If a prolactinoma is greater than a centimeter, then the likelihood of it being surgically cured is much lower. So the advantage of taking, even though that's a small, tiny tumor, almost to the 3 millimeters you may not even be able to see very well on a scan, but it's there, is that actually the smaller ones you can actually take it all out and cure the person. Yeah, so that's in keeping with a 3 millimeter microadenoma, but and the likelihood that that 3 millimeter tumor is causing damage to the rest of the gland is low, but it's nevertheless important to check and make sure that there's no growth hormone overproduction with it, because sometimes prolactin. Okay, well, it's just a rule. I mean, you have to, as a doctor, you have to either decide that you're going to do it or not going to do it, and I think that if you're a careful doctor, you'll just check all the hormones when somebody has a pituitary problem, and just get it over with. 90% of the time, if a tumor is prolactin secreting, about 90% of the time, both the prolactin level will come down and the tumor will shrink.
In how long?
It's variable, but generally the shrinkage begins to develop at anywhere between 4 to 6 months, that you could see it on a follow-up MRI. Sometimes as early as 3 months, sometimes as later as a year, but if it's a prolactin tumor, then 90% of the time it will shrink. And in fact, could shrink to the point of not being visualized anymore.
And that's my question. If she definitely wants surgery, is it a good idea to reduce the tumor so that if you're going to do the surgery, you can't see it, you're going in blind?
Yeah, not necessarily. With prolactinoma, especially if it's being treated with bromocriptine, this is not the case in this case, it's another medication, but bromocriptine, as it's shrinking the tumor, it causes it to become a little bit scarred, and that actually makes it harder for the surgeon to remove it. With Dostonex, we don't see as much of that, and the surgeon, Dr. Kelly, can tell you more about it, but usually the use of cabergoline or Dostonex does not, as it's shrinking the tumor, it doesn't do it in a way that will make subsequent surgery worse or more difficult.
My question is, if it reduces the tumor so that you can't see it, is he going to have any trouble removing that part of that area?
Sure, I mean, if it makes it not visible, then it's going to be hard to take it out. Yeah.
So is it a better idea to leave it alone, because it's going to be a slow-growing tumor anyway, and then go for surgery directly instead of doing further medication?
I think that if you're undecided about the course of treatment, it's better to think about it before you commence any treatment. I think that if you only do it for, you could decide to do a medical treatment for a short period of time just to make sure that you can tolerate the medication, because that may make the decision for you. If you take a cabergoline or bromocriptine, whatever you decide to take, or whatever your doctor recommends, and you have a bad reaction to it, then you really don't have any other options. You can try bromocriptine, you can try cabergoline, and after that we don't have really any more medications that are FDA approved for prolactinomas. Then you only are left with surgery as an option. So that could help your decision. You will know within a few weeks whether that's the case or not, whether there's a bad side effect. Absolutely. I think if the decision is made to pursue surgery as an option, that recommendation is going to depend largely on what the experience of the surgeon is. So for that matter, there's maybe 24 pituitary surgeons in the country that I think have their experience and the volume in order to do pituitary surgery. And if the decision is to choose a surgeon that's outside of those 24 surgeons, then definitely go medical therapy, because the risks of surgery, if done by an inexperienced surgeon, could be catastrophic.
Much more than just taking the drug.
Right. So this is when we're saying that when I'm sitting up here and saying that medical therapy and surgical therapy you could go either way. That's based on having the finest surgeons. The pituitary gland is a specialized form of a surgery. It's not. You can have a brilliant neurosurgeon, but that neurosurgeon may not have enough experience in pituitary tumor. So you have to look and seek out pituitary surgeons specifically.
And especially with her age, even gives you another glitch in the system.
Yeah. If a pituitary surgeon does not do at least 50 pituitary surgeries per year, and this is just a general number, then that's not experienced enough. You have to ask that question. Usually the treatment for a prolactinoma is continued to the point where the tumor has significantly shrunk or gone or disappeared, and the prolactin level is controlled, and then we can begin to reduce the dose of the medication. And there's one study that even shows that once you've made the pituitary tumor go away and the prolactin to be controlled, and then you stop the medication, that those people continue to have no regrowth of the tumor and normal prolactin levels, the majority of them for about 4 or 5 years. But the study didn't go above 4 and 5 years, so we don't know what's going to happen. But I think in general, you have to think of the decision for medical therapy for a prolactinoma that is indefinite, for a microadenoma probably until the age of menopause. I mean, I think there's two kinds of people. There's a kind of person who you tell them that they have a pituitary tumor. This is my experience. And they say, oh my God, I have a pituitary tumor. I want it out the next day. Okay? Or any tumor. You want it out. You know, I don't want a tumor. And then there's another person, and that's me, who's like, I have a pituitary. The last thing I want is surgery. You know, I want to do everything possible and avoid surgery because I'm scared. I don't want to, you know, there's anesthesia. If you don't, you know, there's lots of things with surgery. If I could take a medicine, and this is just a difference in personality. And you have to, you know, whatever your personality is, you have to follow that. But my advice to you is, whatever you decide to do, make sure you're in the hands of good surgeons. The endocrinologist, yeah, it's not so, you know, just coax them to check the rest of the hormones, and you know, at least they're giving you Dostinex, which is good. And it's cabergoline. It's Dostinex. It's Dostinex. It's the same thing. So you know, that's that. But the surgeon is very important if you decide to go the surgical route, and you have to understand that medical therapy is a very good therapy. It doesn't involve any surgery, and some people decide to do that. And I think this is just a fundamental difference in your attitude about it. Probably yes. We usually get to a point where we reduce the medicine. We can sometimes stop it for a number of years. I have patients who take cabergoline. Their tumor is gone. We taper them down. They're off of it for 4 or 5 years. Everything is fine, and then the prolactin creeps up again, and we put them back on Dostinex. And you know, pregnancy raises a whole bunch of other questions and issues that I think you know that are important. But small pituitary tumors tend to stay small, and big pituitary tumors tend to get bigger. So the natural history, because there have been studies that have asked this exact question: okay, I have a pituitary tumor. Okay, so what if I don't do anything about it? Because there's some people who are scared of surgery and scared of medications, don't want to do anything. So what is the natural history of a small pituitary tumor in terms of its size? Is that it's not going to grow. Okay. If it does grow, it will still stay a small tumor. And there's only a 5% chance that it will grow into a big tumor. So the reason you're treating this is not because of the size of the tumor, but because of the hormonal consequences. I'm going to have to say goodbye, but I have to run. But you guys can still talk.